So going on to the technique of indirect ophthalmoscopy, wonderful video has been shown to you. So I just go through the steps one by one to make things more clearer. So the parts of indirect ophthalmoscope have been already nicely explained to you all. Now the most important thing in doing indirect ophthalmoscopy is how to wear the indirect ophthalmoscope, because if you are not comfortable with the instrument, you will never be able to spend time in documenting everything. So the correct positioning and adjustment of the bio headset is very important. There are two knobs, the top knob and the back knob, and that has to be adjusted snugly, fitting the head, but not too tight or not too loose. Because you have to remember that the next 5 minutes you have to spend in examining the posterior pole, the periphery of the fundus, retina, etc. This is the rheostat, which shows the intensity of illumination. The intensity should be moderate. It should never be too bright, because that will cause blinding and the patient will never be comfortable. There will be squeezing, uncomfortable moments, and the crucial documents of the fundus will be left behind. So it should be moderate, which makes the patient comfortable and you also. This is how I am adjusting it. This is the rheostat. Now here is the lever on the bottom part of the slide, which can be moved to converge the illumination and the viewing beams so that stereopsis can be achieved in small pupils. So now you remember what Dr. Abhishek was telling you about the Gallstrand's principle. So this is what it is: the illuminating beam on the top and the two viewing beams, and they all have to be they have to focus pinpoint on the retina for you to get a good image. So this lever helps in doing so. Now the adjustment knob, where you can adjust the height and the angulation of the optics. This is adjusting the interpupillary diameter. There is a knob below which you can just move, just like you do in the operating microscope. The interpupillary diameter will help you to check your IPD. And then you have the important filters: the red free, the yellow and the blue filters. The red free filter blocks the structures below the RPE and enhances the contrast of the retinal blood vessels and the hemorrhages. It helps in the CD assessment ratio, and it also helps to identify the nerve fiber layer. What does the blue filter do? It can enhance the reflectivity of the optic disc drusen, and it is for use in fluorescent angiography also. The yellow filter reduces the UV exposure. So this is the spot size. On the other side you have the spot size, where you can choose the spot size. Sometimes the pupil is very small, so the spot size has to be reduced. Now the most important thing is centering. How do we do the centering? The centering is done against the the tip of the thumb, which is outstretched. So you have to angulate the knob so that the illuminating beam is focusing on the top of your thumb, the tip of the thumb. Now how do we start the indirect ophthalmoscope? First, make sure that the room is darkened. Don't be in a hurry. The room should be darkened. The patient's pupil should be fully dilated and the examiner should be partially dark adapted. The fundus chart is clipped on a rigid board that rests on the patient's chest. It is oriented upside down, where 12 o'clock is facing towards the patient's feet and 6 o'clock is towards the chin. So when we were fellows in Shankar Netale, we had 2-3 things in our mind. Firstly, direct ophthalmoscopes were banned. We could only use the indirect ophthalmoscopes. Secondly, the room had to be having very low intensity. The light had to be dimmed or switched off. The patient should be comfortable. The pupils should be fully dilated. There should be space between your table where the patient is lying and the wall, so that you can move all around the patient. So this is very important. And the other thing is we had to have color pencils in our coat pockets with the fundus chart. Without the fundus chart, indirect ophthalmoscopy has no meaning. What instruction do we give to the patient? Should we just start like that, or should we instruct the patient? You have to tell the patient in their colloquial language that the fellow eye has to be kept open. Sometimes it's difficult. So like Dr. Abhishek so nicely said, you have to ask the patient to look in the different cardinal directions of gaze or use their thumb for fixation. Always the fellow eye has to be open, because you have to remember that otherwise the Bell's phenomenon comes into force and the eye squeeze shut. Holding of the lens also has been explained. I'll just go through it again. The condensing lens is held between the thumb and the index finger, and the free fingers are placed on the patient's face to stabilize the lens and retract the lid. So always remember that when you are doing indirect ophthalmoscopy, the three fingers add as the fulcrum, and they always have to rest on the chin. You cannot be holding the lens and keep your hand in the air, then you will not get the image. So the three fingers have to be placed firmly on the patient's face, and only these two fingers like that move up and down. The light beam should be central, illuminating the pupil completely. Slowly raise the lens while the pupil and the red reflex fills the lens view. This is again important, again I'm repeating it, Kalstran's principle, that is the image, the pupillary space and the fundus of the patient's eye, your condensing lens and the indirect ophthalmoscope all has to be in the same line. If the view goes black or appears inverted, you have moved too far away from the eye. This is the focal length. The first one is, it is correct. The center one is too high up, and the third one is too closely placed on the face. Once we've examined the posterior pole, how do we examine the periphery? The examiner always stands at the opposite end of the meridian to be examined. So to examine the 6 o'clock, the examiner is standing at 12 o'clock and the patient is gazing downwards. The most important query that the postgraduates have is, ma'am, how do we know which quadrant we are actually seeing when we are doing the indirect ophthalmoscopy? The quadrant which is in view is the one which you are examining. So if the patient is looking down and you are seeing the inferior retinal periphery, it is actually the inferior retinal periphery. It is not the superior periphery. It is actually what you are seeing. Only that the image is real and inverted. Do you understand? So if you are seeing the superior periphery, actually it is the superior periphery. Only that the things are right is left and left is right. Okay, so this is one very important thing that you have to understand. And when you are charting, then you have to stand at the opposite side, and as Dr. Abhishek nicely said, the 12 o'clock has to be towards the foot and the 6 o'clock towards the chin, so that when you document it, it is actually in the opposite quadrant, because you are seeing something there and you are documenting it towards you. So what happens is that when you invert the chart, then it comes in the right perspective. Okay, so is that clear? So this is examination of the posterior pole, including the disc and macula, as I have said. This is examination of the inferior periphery. What did I say? The patient is looking downwards and you are standing in the 180-degree opposite quadrant. And then this is the superior periphery. Again, the patient is looking in the same quadrant which you want to examine, the superior retinal periphery, and you are standing 180-degree opposite. And this is like a Bharatnatyam. You have to go all around the patient, tilting your head properly, so that, because if I was standing vertically straight, I would not get this image of the periphery especially. So this is the documentation. Technique of scleral indentation. Once you have mastered the indirect ophthalmoscopy, then only you go on to scleral indentation. What are the advantages? It offers a clear view of the structures in the retinal periphery, that is the ora serrata, posterior border of the ciliary processes. It permits a kinetic examination, allowing a stereoscopic view. I'll go through this slide and then I will explain it with the help of the picture in the next slide. The thimble is placed in the index finger. The blunt tip of the depressor is placed on the skin of the eyelid over the area of sclera to be indented. Now if you're examining the upper fundus periphery, eyelids have to be closed. The depressor tip is applied to the upper lid at the upper edge of the tarsus. And when the patient opens the lid and looks up, the tip of the depressor slides easily under the orbital margin. And the depressor should be tangential to the globe. So this is, I will now explain what I had written in the slide. Now here we are wanting to examine the inferior retinal periphery of the patient. So first you apply the thimble of the depressor in the inferior retinal periphery. जो आपको देखना है, you are seeing the inferior periphery, the thimble also will be in the same quadrant. But what is the patient doing? The patient is looking up. Okay. Now, as soon as you do this in keep this in position, now slowly ask the patient to look down, and then you will see that like butter, the thimble will move back against the inferior tarsus, and you can easily see the inferior structures. So the general concept is that scleral indentation is very painful, ma'am. It's not painful. If you do it correctly, it is a very simple procedure. So this is the advantages. Kansky or other books have this slide. This is again a repetition. 20-D is most commonly used, and with the 3x magnification. Condensing lenses, the general concept is higher power have lesser magnification but a bigger field of view. And this slide everyone knows. So properly done indirect saves the patient's eye, saves your practice, and you can sleep well. This I'll not go through this video because it's already been covered. Can I have the next slide, please? The next talk.
Because I think this is the most important part of the course, the examination. Any queries?
Even basic questions, if you have, because we have a limited audience here, which can be more interactive. Sometimes it is beneficial. So if at all, you all can come in front, whoever is interested, and any questions that come to your mind, feel free to ask.
That I find difficult.
Yeah. So one thing is, whenever you're doing intraoperative, you want to ask. So you are doing a buccal procedure or you're doing a vitrectomy? Yeah. I think it's not. You are covering that topic, intraoperative.
No.
Okay.
I think I'm just going through the difficulties now, so it's okay.
Okay. So in that case, if you are doing buccal, then it is very simple because you have already opened up all the quadrants and you have done it. So intraoperative, while doing vitrectomy, there is a difficulty, but again, what you have to take is the you generally, if we are doing a vitrectomy, we see the fundus through your viewing system only, rather than changing to the indirect ophthalmoscope and then doing the depression. So while doing viewing through the system, you just have to take your cotton tip applicator and in the part that you have to see, you have to just depress it, and you have to move your microscope towards that area, and then you will be able to see it. You have to take care that the tip does not go too deep, because if you go too deep, you will not be seeing the aura itself, you will be seeing the deeper structures only. So it has to be positioned rightly, sort of anteriorly, to have a good view of the aura. And then you ask your assistant to move your tip, just rotate the tip from 5 o'clock to 6 o'clock to 7 o'clock, and that way you can examine the whole of the peripheral aura. Doing an indirect ophthalmoscope, if you have difficulty in scleral indentation, one of the most common causes is you are not able to see the periphery, is that your indenter is not in the same line. What happens is when you have to get a good view of indentation, your eyes, the lens, the patient's area that has to be examined, and the indenter has to be in the same line. Only then you will be able to see what you want to see. Otherwise, you will not be able to see. So if you will be depressing sideways, sometimes the indenter slips sideways. It happens very commonly. Even with experienced hands also it happens. So you have to be, if you are not seeing what you want to see, it means that it is not in the same line. Just check it again and come to the same line, and then you will be able to see. I think that answers the query.
So is it like if patient is not cooperative and not looking in the manner ma'am like asked us to see, then also you are able to see periphery, or there will be some limitation if patient is not cooperative?
Yeah, there will be some limitation. You can put some dilator drop, lubricant drops to just aid in being the patient cooperative. You can decrease the light if you are possible. Or nowadays what we sometimes do is we use that red-free filter and then examine the periphery. Sometimes that also helps. The patient becomes a little bit cooperative in that situations also. Yeah. And sometimes we even if we have to do, if we very badly need to do indentation and the patient is still not cooperating, sometimes we used to, nowadays we don't, because as you master the technique, it becomes unnecessary. Earlier when we were doing our residency days and we absolutely needed the indirect ophthalmoscopy with indentation to be done, we used to even give some facial block in those eyes to get them done so that it does not squeeze the eyes.
Great, sir. Thank you, sir.
Okay, thank you so much.
So one
I
or
just
two
have-
things
yeah.
I'd like to add, Pooja,
Okay, so
for this
okay, for the
technique.
technique. Okay,
Yeah.
sir.
So one thing is, when you are wearing an indirect ophthalmoscope, no, what I feel is the indirect ophthalmoscope is the crown on an ophthalmologist's head, and everybody should be wearing it, right? And whenever you're wearing it, now the weight of the indirect should be at the top of your head, right? It should not be on this. So you should not tighten it from this side, but it should be, the weight should be carried by the top of the head, because if it is not at the top of the head, and if you're tightening with the band from the sides, you do indirect ophthalmoscopy, you'll be having a lot of headache after that. So the indirect should be resting on your top of your head. That is very important, right? And when you're examining, it should not touch your nose, right? Because whenever it touches your nose, you're going to have that nasal burns over here, right? So one thing then dark room is absolutely very necessary, because then you get a better view of the things. Types of lenses you had covered, no?
Yes, that has been covered.
Yeah, the most commonly used is 20 diopters, but you can sometimes, for children, you use the 30 diopter lenses, and even for, if you're examining at the macular lesions you want, you can use the 18 diopter lens also. Sometimes that can be used. Then the history of indirect ophthalmoscopy. See, indirect ophthalmoscopy is such an important investigation. There has only been one Nobel Prize awarded in the field of ophthalmology, right? And that is for invention of indirect ophthalmoscope to Goldstrand, right? He got the Nobel Prize for the invention of indirect ophthalmoscope. So you see how much the importance of this investigation is, right? Yeah. So I move on. Yes.
Yes, that.
Plus 13 plus 14 diopters are also available, but for using the plus 14 diopter, there's a limitation that you have to hold it very far away from the eye, and sometimes it becomes difficult, and pupil needs to be widely dilated for using the 14 diopter lens. Yeah, or you can, there is 2.2 also, which is used very commonly. It gives you both the central as well as the peripheral images very clearly.